So today, Alison and I are really delighted to welcome Professor David Symes, and it's the 13th of July. Things have changed a lot, haven't they, Al, in the last couple of weeks? And it's great to have David on to try and shed some clarity on this complex issue, isn't it, Alison?
It really is. I think, over the last 3 months, we've become very accustomed to mixed messages. Stay at home, go back to work. Social distance, don't go on the tube, but you can go to the pub and meet your friends now. And I think we're seeing that now a little bit within our industry. There's been so much sort of fog. And I guess that's why it's so good to have you today, because everyone's interpreting everything slightly differently. People are desperate for some kind of clarity. But really, which way, in your opinion, David, do you think we should be going at the moment?
Well, it's good to see you all. So, David Symes here. I chair the Joint Council for Cosmetic Practitioners. It's been a very changing and dynamic time, as you quite correctly say, Alison. So the direction of travel has to be based on the principle of patient and public safety. I know we know that, it's a glib statement, but patient safety, public protection, all things gravitate back to that important concept. As indeed is the safety of our employees as well, and ourselves. So it's a societal risk we're trying to manage. I think what is important is that we've all been accused, not individually, but corporately, including the government, on not being able to provide a precise roadmap to where we want to go. That is so frustrating. But we've never lived through a crisis of this nature in our living memories. Some people have. We've got refugees and other colleagues who've lived in incredible uncertainty. But for us, it's really disturbed at equilibrium. So quite a lot of blame out there with these mixed messages. And thank you for saying that. So it's dynamic, it's changing. So I'm going to take us back, if I may, to link to our roadmap to the 3rd of July. That's really the last kind of seminal point when quite definitive guidance appeared quite unexpectedly on a Friday afternoon at 3 o'clock that said, no matter which setting an aesthetic practitioner is working in, i.e. a beauty salon or a clinic, the elective treatments could not be offered. But equally, there was no clarification in that communication from the government whether a medically related treatment could be performed. And it created chaos over a 72-hour period, with an important concept now coming in, trading standards. So trading standards are the organisations that are enforcing the restrictions to prohibited treatments in our sector and in other sectors. So quite a number of our colleagues, if you follow social media, will have been reporting that they've had notices and calls from trading standards officers saying you should not be providing any form of treatment in your clinic. So let's differentiate.
So David, could you just explain that to us a little bit? So the government make an announcement. Yep. So you're on the 3rd. The trading standards are responsible for enforcing the standards, and that was enforced differently across the country. So can you...
Very good point, Adrian. It was. There was absolutely no agreed approach to this at all. We've got concrete evidence, whether it be SafeFace, JCCP, social media. We know from at least 15 different local authorities in England. We are talking about England only at the moment. It's important, where we know that the interpretations were being raised from Salford, who said to all of their Greater Manchester aesthetic practices, you can perform medically related treatments irrespective of what we heard 2 hours ago. Their notice came out at 1700 hours on the 3rd of July, whereas the government announcement came out at 1500. However, you went to Harrogate, or you went to Somerset, or to some of the London boroughs, it was no, you can do nothing at the moment. So what we did was this is quite important, SafeFace, BACN, BCAM, JCCP, we all sought clarification from DHSC, the Department of Health and Social Care as it's known, often called DH, it's Health and Social Care. And we received clarifications quite rapidly on Monday, the 6th of July. I received mine at 5 o'clock that evening from the Department of Health and Social Care saying the interpretation that the JCCP has published on this matter is correct. I'll elaborate what that is. So in a request to the British Association of Cosmetic Nurses, the Department of Health and Social Care elaborated by saying, if a registered healthcare professional is operating from a clinic, now it doesn't have to be a CQC registered clinic, Adrian. That's another misunderstanding. From a healthcare clinic, and is able to demonstrate that they have applied their clinical judgment, their clinical skills, by diagnosing, following a robust assessment of a case-by-case, patient-by-patient, and has written and recorded in a written treatment plan the rationale for that diagnosis, stating the intended benefits and outcomes of that treatment, then the clinical judgment of that individual should be enough to determine that that person is acting professionally to deliver a medically related treatment. However, final point I'll mention, if I may complete this, and I'm speaking a lot of this, it's a crucial point. However, if there is no medical determination, which means any registered healthcare professional, by the way, legal interpretation, not just doctors, nurses, etc., are in this frame. If you're unable to make that diagnosis, or you elect to provide an aesthetic treatment purely for a cosmetic purpose, then it is not legal to do so from any premises, even if they were CQC regulated or registered. So that's the differentiation here, medically related or not.
Brilliant. Well, that's clarified that, David. So Alison, you and I run businesses. So David's more of the regulation side. We're more of the delivery side. So I'm obviously more training. You're on more treatment. How's the journey been for you, Al?
I mean, I think though what you're saying, David, and I understand it. It's only sort of new news because other authorities are saying you can't do this, you can't do that. But the reality is this argument has gone on in our industry for years as to whether do we deliver medical treatments or do we deliver cosmetic treatments. And it has further ramifications with our businesses and the way they are set up. I guess I'm always slightly flawed when I hear it's, you see, to me, I guess it sounds like you're stating the bleeding obvious. Of course you need to diagnose a patient. Of course you need to put a treatment plan, because how can you consent a patient if you haven't informed them about all of those things? But the reality is that all of our patients come to us and I guess it's about educating them though at this time and helping them understand that, you know, some things we can do and some things we can't do. And I think that patients will be very patient at the moment. They've waited this long. I guess the difficulty is, so, you know, as you know, I'm a nurse and I sort of own clinics, but the difficulty is that, you know, some of my colleagues went back in June, and then you've got some clinics that still aren't open. So there's people out there sort of concerned for their business, I guess, I can imagine.
Yeah, and for you, Al, just quickly, so you talked a bit about the medical diagnosis. So you are very strict about your medical diagnosis, but you mentioned that other people aren't quite as strict.
Yeah, I mean, but I think this has always been a case of, I don't know if it sounds crazy, but I don't know if it's because we have really good software computing systems within our clinic. So within that, I've made it that you cannot move forward with a patient's treatment until you've inputted their diagnosis, because only at that point can you input their notes correctly. So it's kind of you have but, you know, there are lots of colleagues out there who, I'm not saying this is common, but, you know, people, if they're not necessarily aware, they might say patient presents with lines in the forehead, therefore 3 areas of Botox treated, this is the dose, off we go, that's it. Whereas that isn't enough as far as I'm concerned from a sort of point of view of treatment and journey planning and all of that. But I think there are a lot of people out there who practice like that.
So I'm going to come in on that and agree with you. So I was a previous chair of the NMC Standards Committee. And one of the things I would have asked, and I'm quite sure my colleagues generations further on would be asking, where is the evidence that you applied your clinical judgment to make a clinical diagnosis, particularly when you're working in your clinics as autonomous practitioners? That's a very important issue. Most of our aesthetic practitioners are working individually or as groups of 2 or 3, sometimes in larger clinics, of course, such as Skin or Transform. We understand that, but there's a governance protocol working with them. But the reliance upon your own individual clinical judgment, and I'm not going to use the word medical here, Adrian, I'm going to use clinical because it covers healthcare professionals rather more broadly. I think we have to be quite cautious about interpretation of a medical diagnosis. That's a doctor's prerogative. A clinical diagnosis would be a nurse. But again, our nurses need to understand, and our physiotherapists or others too, pharmacists, it's within your scope of practice and understanding and confidence and competence. So there's something here about asking a serious question. This is not new. I think you've alluded to this, Alison, in your earlier point. So I would expect every qualified healthcare professional who's practicing in aesthetics to apply what is required of any nurse, doctor, dentist, etc., in their code. And their code of practice requires them to have recorded an evidence-based rationale, assessment and treatment plan. If it can be digitalized using a computer-based program, superb. And I agree, I see this as gateways to any progression in a care plan. So you can't move on to treatment till you've recorded a diagnosis. Fantastic. But the reality is, and you're right, there are many of our practitioners that don't have that level of sophistication in their clinics. But there's no excuse not to have an audit or evidence trail which identifies the reason for your treatment, the conversation you've had with your patient, of course your consent form, which has to be based on informed consent, that should be detailed, but equally it's the follow-on journey, it's the consequences of the treatment. What were the intended benefits, psychological and or physical, of this intervention? And what were the actual perceived and considered outcomes for the patient through their own objective measurement of their experience? So that audit doesn't just start and stop with the assessment. It's about any untoward events, any adverse incidents, how your journey's moved on. So you have an improvement journey. That is not new. That is baseline practice for any doctor, nurse, dentist, physiotherapist, pharmacist. So I'm afraid we're perhaps revisiting what many of us knew, but may not be universally applied or applicable. But I can assure you, trading standards officers have told folks last week, show me the evidence of your evidence trail, then that will give us the confidence to agree that you are working with a medically related treatment on a case-by-case basis.
Yeah. So Al, would you mind, you've been back working really hard, haven't you, for the last week or so?
Yeah.
A bit more than a week. How's practice been for you? And also, what evidence are you putting down, documenting for the medical basis of treatment?
Okay, I'll tell you my experience, but I'll also talk about, colleagues of mine that I've spoken to. I think the really strange thing is London is a very strange, weird place. Okay, I keep joking. I live in Clapham. One of my clinics is here. You wouldn't think there was coronavirus in Clapham. You wouldn't think. No one wears it. Outside of clinic, I'm talking about at the moment. No one wears a mask. People aren't social distancing anymore. Our local council have taken the decision to pedestrianise the road near where my clinic is so that it can all become bars and restaurants over the weekend. So in London, people are very much, the only place I'm consistently seeing masks or social distancing is on the trains. Otherwise, there is it's just, everyone has just kind of said enough and sort of come back. So, patients, we've set out the clinic, so we've got social distancing, they can't use the bathroom, they have allocated appointment times, and patients are being very good at sort of understanding and all of that kind of thing. But has my practice changed dramatically? We are one of those clinics though that always cleans the sides, always, we have cleaning rotas that have to be signed regularly, So with regards to how much more work it's added to the clinic, it doesn't feel vast. I must admit, when I first came in and set the clinic up, I had a sort of a sad moment thinking, is this the view of it? Because all the niceties have been taken away, all of this sort of thing. But in some ways that reminds us we are a medical clinic. That is it. At the end of the day, we are a medical clinic. So patients come in, patients are very understanding that things have had to change and that we are sort of limiting some of the treatments that we do. But I don't suppose, I've always given the patients a diagnosis. I've always given them a treatment plan because part of that is important for their consent. So that part of my work hasn't changed.
So can I just ask you one important point? And it's not personal to you, Alison, but it's more a general question here. One of the things I've heard trading standards officers advise me in the last week, or at least in correspondence, has been the public face of clinics to members of the public. In other words, advertising, social media, and obviously your website. So one of the things they've actually asked, quite remotely, they've actually asked questions which have risen from the fact that they've inspected websites that have seen nothing to differentiate a clinic from a beauty salon. I think that's quite an important question. Now, I'm not here to judge that. We're trying to be helpful to members of the public and others listening to our conversation today, but I do think that's quite an important issue for you to be asking yourselves. What is your website telling members of the public and indeed those who are required to enforce the current legislative restrictions?
Yeah, I guess you're right. When you go onto our website and you go onto the home and you go on to meet the team, straight away it is me talking about my qualifications and the fact that we are a medically led, clinical led clinic, that we do uphold all of those things. So I guess, but I keep saying this, David, I don't think any of this is new. We should have been doing this for years. And I think that, I know I'm not always politically correct. I don't always please people, but maybe this will sort out the real clinics and the ones that are sort of doing a hobbyist. It's not what this is.
Yeah, Al, you might be right. Now, just give us an example. So what treatments have you generally been doing? Have you been doing just mainly botulinum toxins or fillers?
So a lot of sort of botulinum toxins and dermal fillers. We, intraorally, we're shying away from treatments because it's not something that we sort of desperately need to do. And we're not actually really doing anything new. So I would say we're sort of maintaining, because a lot of these patients would have had a treatment plan over the beginning of the year. So we're completing their treatment plan for their treatment of botulinum toxin or things, but we're not really. If patients are saying to me, oh, I've been thinking about this, it's like, well, if you've been thinking about it, why don't you think about it for a little bit longer as well? And we'll do that as the time goes forward.
And what documentation and medical diagnosis are you tending to put down?
So it all totally depends. So if it's fillers, it might be a sort of asymmetry, focal volume loss. So it all sort of static righted, solar elastosis. It's all those sorts of things. And then, like I say, though, do you know what's interesting? We're not seeing new patients. So we're not having to make new diagnosis or new treatment plans at the moment. Most of ours is continued treatment plans. Interestingly though, saying that, we had one patient ring up this morning, a brand new patient ringing up for the very first time asking us, do we use pure botulinum toxin? I've never been asked that in all my life. People just sort of, so I think patients now are being slightly more considered to a certain extent. Not seeing the influx of new clients.
Yeah, I wonder what they think you might be using if you're not using pure botulinum toxin.
I think because they know that these are, all the different ones. I think they want the brand. That's kind of what they want. I stopped using water ages ago, Adrian.
It doesn't work very well, does it? Yeah. So, David, where are we? So from my understanding, medical diagnosis, treatment plan. Now, what about beauticians in non-CSQ, in non-regulated premises, David?
Yeah. So we know the decision was made by government for beauty salons to open. And again, that was a little bit strange last Thursday. We weren't terribly sure what that would mean. Excuse me. By the evening, we'd realised that there was a list of restricted treatments that had actually been produced very rapidly. Well, so it should be. You're sending an announcement at 3 and you're on your way again planning. So effectively, non-invasive treatments any form of invasive treatment cannot be performed by a beauty therapist. So by definition, beauty therapists cannot provide a medically related treatment themselves because that requires a healthcare professional to make that determination clinically. So that's, I think, a critical differentiation. What is very clear is that any treatments above the neck effectively cannot be given by a beauty therapist at this present time. So, for example, any injectable form of toxin or lip enhancer or filler cannot be given by injection, particularly, as I say, above the neckline. And that has been very clearly stated. But just to remind us, we have not mentioned this, but the COVID-related healthcare protection factors are of paramount importance here, no matter what treatment's being given. So, for example, I was talking to a couple of colleagues. They said, well, of course, you can have a simple screen if you're dealing with nails or you're dealing with matters, pop them under the screen. You can be very safe indeed. But I think what we do need to remember, the importance of PPE might be going up a notch to include visors in the future, not just FFP2 or 3 masks for aerosol generating procedures. So visors is something to put on the menu today to be very aware of. After all, if hairdressers are using them, it seems pretty clear to me we should be very clear. But that's the basic line. It's a limited scope. It's a published list of what treatments can be offered in beauty salons, but it's not the treatments that I would be registering or regulating at JCCP.
Okay, and visors are considered safer than masks?
They are. They are considered safer. Of course, we need to remember if we're dealing with aerosol generating procedures in their own right for the protection of the individual and of anybody else, you may want to have a mask and a visor. I'm not going into the actual benefits of that, but I think we should be thinking of a simple facial covering of where a visor is clearly more protective with regard to the spread.
The challenge that we have with a mask, hang on.
If you got it the right way up, Al.
Here's the right way, thank you. So, the challenge that we have as a practitioner with a mask, I totally understand it. It's very often when we communicate, for everyone who's not watching this and listening to it, I'm wearing a mask now. When we communicate with patients, we use our own faces quite a lot.
Yes.
So we will very often say to patients, okay, this is the area we're beginning to talk around here. So I think the visor thing is a really interesting thing about their safety versus mask, because also if we are injecting fillers, we are having to ask the patient to remove their masks, but we're obviously continuing to wear our masks. But bearing in mind we're in the industry of faces, it is quite obstructive covering our faces, particularly for new patients, because new patients, when they come in, a big part of them deciding, are you the right person to treat them very often, is what you look like, because that gives them safety. But the reality is, David, you know, what you're saying when it comes to beauty therapists doing any kind of injectable, any kind of medical treatment, they shouldn't be doing that whenever in the world if they're not medically supervised. Well, they shouldn't be doing it full stop, but if you've got an aesthetic practitioner like our laser girls, they should never be practicing without some kind of supervision.
No, so the supervision is something we've always been very clear about, but we must remind ourselves in the United Kingdom, it is legal for any person to actually inject. Now, the question for me is the legality is one issue, but even more important, that is there is no requirement for a non-healthcare regulated healthcare professional to either be insured or to be trained to any standard. There's not a legal requirement to be insured. If you're a healthcare professional, there's a legal requirement, without a doubt. So there's a paradox here, isn't there? That your point of a general statement, who should be permitted to perform these higher risk treatments is one thing, but in the absence of a mandated training standard, of evidence-based standard, then, and the insurance factor, it becomes even more compounded. They're critical issues for me for public protection, and ones that I and many others continue to lobby government on. And to me, it's a pretty fail-safe challenge here. But I think what we must remind ourselves, we are seen to be very adverse in this country to managing that risk in other ways. So I remember for one example on a national platform in Manchester, describing the current legislative structure of the UK in this regard. And I was absolutely rubbished and challenged by a colleague from the United States, a very senior dermatologist, international renown. And I really felt I was having bricks and mortar thrown at me at the greatest rate, with a Sten gun. But it suddenly made me realise, well, this is something we've got to recognise. I couldn't even defend the fact that.
And David, what was his point? What was he chucking at you?
Well, she was actually chucking at me a very clear statement. How could you, in the United Kingdom, allow a non-healthcare professional to actually inject with such a high risk of challenge, particularly in the absence of a regulated standard or register to require that?
So quite a difficult one to answer for you, Dave. Uh,
A very difficult one for me to answer, and I won't be drawn further. But
no.
the issue is, though, I can be drawn on the standards issue, because that is something Health Education England, that I chaired their original work, were very clear on. If you can't demonstrate your ability and competence and knowledge levels to practice at the requisite grad, and we say level 7, then you should not be actually providing such treatments without supervision.
Yeah, but we talked about this before, Dave. The difficulty for you is that if it's not illegal, it's very difficult for you to police things, without illegal.
Yeah. It's not illegal. And I think we need to be very clear. It is legal in this country. So
Yes.
it's a matter of opinion, but public protection says, and I think Alison made a very good point, the public are becoming more aware now of questions to ask.
Yes.
So I would certainly be encouraging any member of the public to ask an anaesthetician or a beauty therapist a simple question.
Yeah.
Are you qualified to deliver this treatment? Where is the evidence of your qualification and your insurance certificate?
David, you'll be absolutely floored. The number of patients that I sometimes get who come in and say to me, oh no, my beauty therapist told me that I shouldn't have injectables, or my beauty therapist has told me. These beauty therapists seem to be next to God in a lot of the general public's eyes, because they've grown up with them. They've been seeing them, their facials and all of that. So I think that, but I guess, David, what does this mean now for us on the 13th of July? Should we be not delivering, so should we be delivering elective cosmetics? So a patient walks in, I want to have more beautiful, voluptuous lips. We should be saying no until when?
Well, we don't know the when. I don't think it's that far off. That I really don't know. So no matter whoever thinks that they know, even the Department of Health and Social Care, I believe, do not know from one day to the next, because the actual legislation and the guidance is being produced by another department linked to the cabinet. So I'm confident this is a constantly changing political feast. My guess is, how much longer can the restrictions apply? Now, subject to no sudden surge in COVID activity, because we must always remember that could always occur at any time, which would make the government very nervous about relaxing any further restrictions. So if we're in a constant pattern, as we have been for a little while now, says David, very cautiously thinking about that, I believe that we will be in a position to see all restrictions lifted, i.e. medically related or otherwise, as long as we follow social distancing, the PPE and the best practice guidance by the end of July. I really believe that is the feeling that most of us have. But it's not evidence-based, Alison, we can't confirm that.
Yeah. And David, sorry, would you think this may be an opportunity, to resolve the issue of non-medically qualified people doing? Do you think this is, potentially got an upside?
There's an upside, but Adrian, the upside of this is also very challenging. It started at the beginning of the conversation when we tried to determine or define what is a medically related treatment. So conversations with CQC, our Care Quality Commission, for example, would ask the question, should these treatments be actually regulated or restricted? Now, the answer is at the moment no, and CQC are very clear. They will only seek to regulate a healthcare practitioner, not a beauty therapist, end of, no matter what they did. So to me, the question starts with, should we be identifying these treatments as medically related? Can we have that conversation during and now post-COVID? We're not post yet, but during and towards post-COVID, because I think it will now force the argument of what is a medically related procedure. Because I can assure you, I'm asking that question now. So are many of my colleagues. It's not one we can elude or evade for much longer, I think, Adrian. That will then lead to those other questions.
Brilliant. Well, I mean, that's cleared a lot up for me. But as you say, it's a rapidly changing, no one really knows. There's lots of, controversies.
Sorry, something else. I think the problem is also at the moment, David, and this is not no one's fault, but it's the way of the world. It feels like there's a lot of double standards out there. So, and I'm hearing this a lot. Now, all of a sudden, a lot of people won't take the tube to work. So they're being asked to go back to work in the city, and they're saying no. Their employers are making their offices more than safe, but they're saying no. However, my clinic in Battersea is right next to a pub. Last Saturday, or 2 weeks ago Saturday, when the pub opened, I was working. It was the first day, and I was working, seeing patients. And by the time I left clinic at 4 o'clock in the afternoon, there was 200 people outside the pub. So they're not able to go on a tube, but they are able to go to the pub. And when I think about the risk of delivering a treatment, and I totally understand it and I get it, but I can see how some practitioners will be saying, do you know what, bugger this. The reality is the risk of me doing a treatment with all my PPE and all my sort of sterile, clean procedures versus going to the pub on a Saturday night, it doesn't make sense. And I think that's what people are now struggling with.
And they are struggling with that, and we hear it constantly and continuously. So I think the issue is, and I think it's a misunderstanding, to be frank, that there is a view that only healthcare professionals can practice safe health protection and public protection. I wish I could say that were true, but there again, why would I? We know that some of our healthcare professionals are not practicing as they should, I'm afraid. Only a minority, I guess, but I'm making a point here. But we've got evidence of some excellent beauty therapists who are also providing superb COVID-related practices, I should say, within the restrictions. But look at our hairdressers. I've gone past many recently, working till 10 o'clock at night, staggering their hours, working on Sunday afternoons, waving through the door, visors on, screens between chairs. So it doesn't take a healthcare professional to operate to the full extent the COVID-related procedures, but it does take a healthcare professional to make the medically related diagnostic requirements from a clinical perspective. So there are double standards. I couldn't agree more with you, but we do have to always remember our role, particularly as accountable healthcare professionals. It's public protection first, follow the legal line, because if we don't, then our insurance will be invalid, and certainly our healthcare professional regulator, we will actually fall foul because we won't have the evidence to show we've acted responsibly, always putting the patient and the public interest first.
Well, I think that's been brilliant, David. I think, it's really clarified it for me. Al, have you got anything else you'd like to add? Any more clarification required?
I better stop doing those discount lip jobs then, hadn't I, David, by the sounds of it?
You better. And also, it's 3 bottles of champagne that you're offering on the internet. I'm only joking.
Yeah, and Al, I think the more you can cover your face, the better sometimes. You don't mind me saying.
That's certainly true in my case. I could have.
And Adrian.
Yeah. So, Al, you back to work now?
Yes, 3 o'clock. Just a few more. It's really lovely though. The pace is amazing. And I tell you what else is really lovely. We live in an area where there's a really high birth rate. It's called Nappy Valley. We have a lot of, so it's not uncommon for women to come in and ask their little darlings to sit in the waiting room while they come into treatment quickly. But it just means it can be chaotic. The clinic is so calm. It's amazing because only the patients coming in at their appointment time. They're not bringing their family to sit in the waiting room. It is really nice working environment.
I think that's another thing. So you're on time as well, aren't you? You're not rushing. You've got enough time.
Yeah.
Yeah.
So
the benefit of all of this, actually, if there is a benefit, that has been an amazing benefit to have enforced time to reflect.
So my clinics, I used to have 50, 60 people in the clinic in Harley Street. And now, I'm doing virtual consultations with the majority of the patients. And it's I think the patient care is actually much better. So, every cloud has a silver lining, doesn't it?
Absolutely. Well, it's lovely talking to you both.
Yes. And you.
We love your garden, David.
Thank you. Yes, I'm going to go and spend half an hour there before I go on to my next call. Just pot around.
Brilliant. Thank you very much for joining us, David.
Pleasure, Alison, and keep safe.
And
stay pink.
Oh, thank you.
Nice to see you,
guys. Bye-bye.